Welcome to another episode of the MEGIN Spotlight series. We are delighted to have Dr. Vahe Poghosyan, head of the MEG department at King Fahd Medical City National Neuroscience Institute in Riyadh in Saudi Arabia. Hello Vahe, thanks for joining us today.
Hello Gabriel, thank you for inviting me.
Just to give our audience some background about the hospital, KFMC has a strategic location in the heart of Riyadh city, the capital of Saudi Arabia, and is one of the largest and fastest growing medical complexes in the Middle East with a total capacity of 1,200 beds. It is also one of the most advanced hospitals in the region. The team at KFMC is engaged to achieve one goal, making the hospital a benchmark in the medical care, to which all patients from all over the region are referred to for all treatment levels, where medical and professional competencies of different disciplines are gathered to provide assistance to patients. KFMC is estimated annually to treat more than 30,000 inpatients and 500,000 outpatients, which is incredible. So Vahe, please tell our audience today how and why was the decision made back in 2011 to utilize MEG technology to solve neurological problems of the patients at KFMC?
Actually, it was before my time here. I joined KFMC in 2016, so I don't know the exact details, but what I can tell is that the comprehensive epilepsy program and the National Neuroscience Institute were established in KFMC in 2011, and the aim was to build the most advanced epilepsy program and clinical neuroscience center in the region. And as such, MEG was considered an essential tool to have, primarily for the epilepsy program, but also for conducting brain research.
So knowing that from a clinical perspective, MEG is primarily used in KFMC's epilepsy program, please could you elaborate on some detail of how MEG technology is incorporated in the institution's operational flow?
MEG actually is part of our routine workup for patients with drug-resistant epilepsy. Nearly all patients that are admitted to our EMU are undergoing MEG in addition to other evaluations. After admission, we normally wait for the patient to be weaned off medication and then scan them when they are off medication. This, in my experience, significantly increases the yield of MEG actually for epilepsy localization. And in general, actually, we're trying to scan all our patients in an inpatient setting because in this way we have more control over what, when, and how to scan the patients, and we can really ensure all of the necessary conditions. For example, we can make sure the patient is sleep deprived. We can scan patients when they have already frequent spikes in their video EEG. Scanning inpatients is also convenient if you want to repeat the measurements, such as, let's say, if you have a poor data quality or we didn't report enough spikes, we can then repeat the measurement, and when patient is inside of the hospital, it's much easier to make these measurements. We of course record patients also in outpatient settings, but these are mostly for functional cortical mapping or the patients which have been referred to us from other hospitals for MEG only. For epilepsy localization, actually, we typically scan our patients for 1 hour or more if necessary. Again, for inpatients from the video EEG, we know if the patients have rare spikes, when we'll scan them longer. But if the patients have frequent spikes, then we limit our measurements to 1 hour. Normally, after MEG measure, after the epilepsy recording, we also language mapping, functional cortical mapping for language function. But in some cases, sometimes when the patients are tired or they refuse to perform the task right after the measurement, we schedule them as outpatients. Then as soon as we record the data, we start analyzing it immediately, and when the results are ready, they are discussed in epilepsy patient management conference together with the results from all other techniques. And normally the case is not scheduled in our hospital for patient management conference unless all evaluations, including MEG, are ready. So, and in many these patient management decisions, MEG plays really an important role in our hospital. So, for example, in a number of cases, it may tip the balance towards sending patients for surgery, or in most cases, I would say it provides the brain regions that need to be covered during the invasive recordings. And with time, actually, as our epileptologists and neurosurgeons got more familiar with MEG and knew what to expect actually from MEG in different cases, the impact of MEG in these epilepsy patient management decisions has significantly increased actually. And after these management conferences, let's say in the cases where a decision is made to send the patient for surgery, we can really directly then communicate with neurosurgeons, provide them with more precise localization information, let's say in a DICOM format, which can they then import into their neuronavigation software and use that information to guide the placement of intracranial electrodes or for surgery.
Thank you. From a hospital administration perspective then, how has the hospital achieved their ROI of having MEG technology as a standard in your Epilepsy and Neuroscience Institute? Have you seen an increase in the number of scans in the last 5 years?
In the past 5 years, actually, the number of our MEG patients have steadily increased, approximately 25% per year. So in 2017, we scanned 72 patients, and last year we had 144 patients. So it's exactly doubled it. Mm-hmm. So our estimate is that this year we will have around 160 patients. About 70% of clinical MEG studies in our hospital are done for epilepsy localization. Another 30% are for functional cortical mapping. I mean, I'm not sure about the exact ROI in terms of financial returns for the hospital, but I know that the hospital is happy with MEG, and we are planning to upgrade our system within the next 2 years. Currently, we have a vector view system, which was installed in 2011, and we are planning to get the new tube system with liquid recycling system, which I guess will increase the ROI even further.
Do you feel MEG has been adopted as an essential tool for treatment of neurological diseases and conditions in Saudi Arabia then?
I wouldn't say that it has been accepted or it is an essential tool in all of Saudi Arabia, but it is certainly an essential tool in our hospital, especially for epilepsy localization and functional cortical mapping. Our system is the only one in Saudi Arabia, so we're working with other hospitals, especially the ones which have comprehensive epilepsy programs, to raise the awareness of MEG among the physicians. Currently we receive regular referrals from 4 hospitals from different regions in Saudi Arabia, and with these hospitals actually we'll already establish kind of robust patient flow process, which makes very easy for both the patients to come to us and also for the referring physicians to refer the patient and receive back the report in time for their patient conferences. I mean, such patients, the external patients, we typically scan as outpatients, but if necessary, we sometimes admit them also.
In your view, has MEG technology made a difference then to epilepsy patients? And if so, can you share a specific case maybe that would illustrate how MEG has been vital in their diagnostic process?
I mean, MEG is making a big difference, and this is something to our patients, and this is something we see all the time. Regarding the specific case, recently we had a case of an 18-year-old patient actually who was suffering from seizures for 13 years since he was 5 years old. And at the end, he was actually on 4 different anti-seizure medication, but was having 30 to 40 seizures per day. So he was really suffering. And all evaluations, like including semiology, EEG, MRI, PET, all of these evaluations, they pointed to a frontal lobe onset. However, despite the lesion in the right frontal cortex, the EEG was very diffuse and multifocal, both coming from both left and right frontal lobes, and the semiology was not lateralizing. So MEG identified actually several sources inside of the lesion, around it, and also in some extralesional regions, including anterior insula. So then the patient proceeded to phase 2 invasive evaluation, where the electrodes were placed. I mean, we do stereo EEG, so stereo EEG electrodes were placed in both left and right frontal lobe, including all of the sources, show all of the brain region indicated by MEG. I just would like to emphasize here that some of these regions would not have been covered by intracranial recordings if not for MEG. Then the seizure onset zone actually was identified from some of the electrodes covering the MEG sources, including the one in anterior insula. The patient, I mean, all of these regions have been resected, and for now, it's already several months, patient is free of any seizures. So I think it's one of the very good examples how MEG really helped to a specific patient.
That's incredible. That's great news, I think. So let's talk about a little bit about MEG data analysis. So often we hear from patients and physicians that it can take a long time to receive a comprehensive report from the MEG lab once a patient has been scanned. And can you give us some insight into this in regards to what the complexities are and how you overcome these in your institute? I mean, what are your average response times in regards to patient reports, for example?
Okay, in my opinion, actually, the timing of MEG report is really an important issue. Actually, the late reports, I think, are a serious problem for wider utilization of MEG. And I kind of will explain why. Let's say when a physician, be that a neurologist or a neurosurgeon, doesn't receive the report in time for, let's say, epilepsy patient management conference or for the surgery, or for that matter, for any other instance where they need MEG results to make a decision, then if the results are not there, they will ignore the MEG data and proceed with their decisions, proceed with their course of action without the knowledge from MEG. And with time, especially in the hospitals where MEG is new or where the physicians are not really used to MEG yet so much, they will stop referring patients to MEG, because they don't get their results on time. And this significantly reduces the utilization, the clinical utilization of MEG. I mean, okay, on the other hand, the referring physicians must also understand that MEG is a very complex technique, and it takes some time to properly actually process and analyze the data. I mean, here when we just started with MEG, and even now, some physicians who are not yet very much used to MEG, they would refer their patients, then we do the recording, and the next day of the scan they would call and tell, we couldn't find the report in the system, or the results ready. So I guess it's up to us MEGers to educate our colleagues on the complexities of the MEG technique. I guess agree on some kind of a time frame with them on when the reports must be submitted, how long, and consistently submit a report in that time, so that they really can utilize and MEG can be useful for them. I mean, regarding the complexities, MEG provides very rich information, richer than any other technique that is richer and actually more complex than any other technique that is used in epilepsy evaluation. This is somehow both. It's the blessing of MEG and its curse. I mean, it is good because of this kind of rich information. MEG is able really to provide unique and clinically useful information, which makes a significant impact, actually significantly affects the epilepsy evaluation and the surgical outcomes. I mean, there are a number of studies have shown this. On the other hand, because it provides so much information, the information is so complex data, it takes, you need actually a lot of advanced techniques and a lot of detailed analysis to really gain advantage of it. And and this is a time-consuming process, this kind of analysis. So therefore, the analysis of MEGIN data takes really long. I mean, since the data analysis procedures, the software people use, the computing power and the expertise really substantially varies from center to center, I can tell only about our lab. Let's say in our lab, the initial inspection of the data after the recording, the initial inspection and pre-processing of the data takes about a few days. Then there is a visual review of the data for identification of epileptic events, which takes another day or so. Then there is the source analysis of these events and interpretation of the data, which also takes some time. Sometimes even we need to go back to the previous stages of the workflow to clarify several issues. I mean, all of these things each of these processes is time consuming. So another major reason actually for the delays is the limited staff in MEG labs. I mean, typically MEG labs, at least in our case, and I know several other labs, have very few technicians. Now because of this one, because you have few technicians, the same people who are preparing the patient, conducting the recording, they're also the people who are involved in the data analysis. So this naturally delays the data analysis and the report. So, I mean, okay, let's say in our case, just an example, if we have 2-3 patients per day, for that day, 2 of the technicians will be busy making the measurements, and so we will not be able to perform data analysis, and therefore this analysis part will be delayed. So currently, in our case, we submit our reports within 10 working days, but actually this was not always the case. It used to take much longer before, but past several years, one of our KPIs was one of our main KPIs actually was the time it takes from the measurement to the report. And our aim was to submit 80% of our reports within 10 working days. I mean, it took some streamlining, fine-tuning of software, procedures, staff reallocations, but we actually finally achieved it actually. And I think 10 days is a reasonable time for submitting a report. Although I know that there are some other labs which do this much faster. They submit the reports within a few days. I mean, in our case, how we achieved this actually took probably about a year of this transformation. We established a clear staged workflow and with specific timeframes for each stage and responsible people. And then once a week we're meeting and discussing all of the unreported cases and to see if we are on schedule and making actually plans on how to fix any problems or if we are, deviated from our plan. So that's.
That sounds good. You've done major improvements. I think that's great. Apart from epilepsy then, and what other neurological pathways is MEG technology utilized at KFMC? You mentioned language mapping earlier, so what other areas?
Yeah, in addition to language mapping, we perform also functional cortical mapping. And primarily, actually, it's a language lateralization, but we also do language mapping. We do visual auditory mapping and sensory motor mapping. About, I would say, 30% actually of our clinical MEG studies are for functional cortical mapping. I mean, in our hospital, just to note that WADA test for language lateralization or for memory lateralization is very seldom used. We primarily use MEG for these purposes.
And does MEG technology assist in any planned research projects at KFMC? Sorry. If so, are you able to disclose and perhaps share any projects?
Yeah, sure. I mean, we are involved in a number of research projects. In general, we focus on 2 research lines. First is to improve the yield of MEG in epilepsy localization, to develop methods for this purpose. And this includes methods for automatic detection of epileptic spikes, improve the source analysis, or identification. Actually, it's one of the things which recently started, identification of biomarkers for localizing epileptogenic zone, which do not really need the visual review of the data or identification of some discrete events. And the second line of research that we focus on is neurobiological underpinnings and candidate biomarkers for psychiatric and neurological disorders, such as depression, obesity, psychogenic non-epileptic seizures. We have some studies on autism and this type of stuff.
Well, thank you, Vahe. We've come to the end of our segment today. So this has been extremely informative for our audience, and it is an honor for us to be able to share insights into MEG utilization in prestigious and advanced institutions such as KFMC. So to communicate this to the wider MEG audience for us is globally is exactly the aim of our spotlights. So thanks again for your support today. I appreciate it.
Yeah, thank you very much. Thank you very much for inviting.